here to Dr. Doyle as he talks with us today.
All right, thank you, Sally. So just to give everyone an idea very briefly of what I hope to do today in terms of what we'll cover. I'll talk a little bit about the history of treatment in general for anorexia nervosa, which at this point is not as long and illustrious as we might like. I'll talk a little bit about the development of family-based treatment, or the Maudsley Approach, for adolescent anorexia nervosa. We'll do an overview of the treatment, talk about the empirical support, and then at the end I'll briefly review how one might go about making referrals and improving those referrals, and if anyone is interested in seeking further training, how you would go about doing that. So very high-level overview, just thinking about the eating disorders that are currently in the Diagnostic and Statistical Manual. The 4th edition, these will actually change for the 5th edition, due out in May. But right now we think of eating disorders as being anorexia nervosa, bulimia nervosa, which is characterized more by binge and purge episodes, and then eating disorder not otherwise specified, which is kind of a catch-all category. And I think it's nicely represented by this picture, where you can see the largest category is eating disorder not otherwise specified. A subset of people who would qualify for that diagnosis would meet the diagnostic criteria for bulimia nervosa, and then an even smaller subset from there would meet criteria for anorexia nervosa. Now, I should say that when we're talking about base rates in the community, right now the best estimates are somewhere between 1/2 and 1% of people in the United States would meet criteria for anorexia nervosa. Of those, 9 out of 10 would be female, but there's still some question about whether or not those numbers are entirely accurate, or whether or not we're seeing a full representation of males with eating disorders. It may be, and probably is to a certain extent, the case that men are less likely to present with eating disorders. It's still thought of, I think, in general terms as being a women's disorder. But we know that that's not the case, and hopefully over the years that will that stigma will be reduced, and we'll be able to help people, because the other part of that is that people who identify it as a women's disorder, if they're male, are less likely to come in for treatment because of that. So when we think about the animal that is anorexia nervosa and the diagnostic criteria as they currently exist, there are 4 right now. First is the refusal to maintain weight at what we would consider a normal weight or a minimally normal weight for age and height. So the weight criteria. The B criterion, intense fear of gaining weight even though they are underweight. The C criterion is the undue influence of body shape and weight on how one experiences themselves, or denial of their low weight, even though it's particularly serious. And then the D criterion, that there's an absence of menstrual periods in postmenarchal females. Now, when we move to DSM-5 in a couple of months, the D criterion is actually going to be removed, or at least that's what all the people that I've talked to on the committee are saying, that that was the consensus. And that was just because in doing the research and in reviewing the research over the last 10 or 15 years, it seems that there is no significant difference in terms of presentation, in terms of duration of illness, response to treatment, etc., for those who are meeting the A, B, and C criterion, but not the D criterion. And so it doesn't seem to be a valuable criterion in terms of differentiating folks in terms of their response to treatment or the seriousness of presentation of their symptoms. So that'll be removed in a few months. All right, so if we think back to when does treatment and the focus on anorexia really begin? And this really doesn't take place until about the middle of the 19th century over in Europe. And I've got a couple slides here that just, I think, are representative of the way that we used to think about treatment for anorexia nervosa. William Gull in England in the mid-19th century says patients should be fed at regular intervals and surrounded by persons who would have moral control over them, relatives and friends being generally the worst attendants. Across the pond in France, Charcot has a similar feeling on this. It is necessary to separate both children and adults from their mother and father, whose influence, as experience teaches, is particularly pernicious. Now, when I have talked about this in trainings and presentations that I've done with families of patients with eating disorders, this slide always gets a lot of grumbling because everyone can agree that we rarely think of parents as being particularly pernicious anymore. In fact, as we'll talk about, they're a very necessary part of treatment, especially in this disorder. By the 20th century, then, this notion of the parentectomy has become part of what we think about with treatment and removing parents as a necessary part. And this certainly isn't just true in anorexia nervosa. This is the case in a lot of disorders, especially early on in the 20th century, most notably maybe the schizophrenic mother, and thinking about schizophrenia treatment and the way that we would conceptualize schizophrenia in the psychology world, and really attaching a lot of blame and a lot of responsibility to the parents and the environment that the parents set up for a child. And so this is a pretty common way of thinking about anorexia, at least in the first half of the 20th century. By the second half, then, family therapy, and particularly structural family therapy, are starting to chisel away at this notion and starting to really think more about how do we imagine the family being not only not detrimental to treatment, but a really important piece of furthering treatment and helping people as they're battling different disorders, and particularly in the eating disorders. And so it's out of this tradition and out of this shift away from the 19th century notion of keeping the parents out of treatment, doing individualized treatment, seeing the parents as part of the problem rather than part of the solution, that family-based treatment, or the Maudsley Approach, emerges. And this is a nice quote from Yvonne Eisler, who was part of the original treatment team at the Maudsley Hospital in London, who developed this approach. And he says, "There's little doubt that the presence of an eating disorder has a major impact on family life. With time, food, eating, and their concomitant concerns begin to saturate the family fabric. Consequently, daily family routines, as well as coping and problem-solving behaviors, are all affected." And basically, what Yvonne Eisler and Christopher Dare and Gerald Russell and the others at the Maudsley at the time felt was that really, maybe we're coming at this from the wrong direction. Maybe we're seeing the eating disorder as being caused by the problematic family structure, when in reality what's happening is the family structure is being shaped and distorted by the presence of the eating disorder. That the family structure is not what caused the eating disorder, but rather the reason that we see families in such a state when they come to present is because of the fact that they are dealing with this eating disorder. And when we think about that, I think it makes a lot of sense. When parents come in and when I see families who are presenting for the first time and their son or daughter has anorexia nervosa, they're very scared. They're very upset. They're very worried about what's happening. They've seen usually a child who has been doing well in school, has been doing well socially, has always had a pretty good command of life, starting to falter and starting to exhibit some really frightening behaviors. And there's usually by that point been talk about hospitalization, inpatient stays, and so they're coming to you at a time when this eating disorder has really caused a lot of chaos in the family and a lot of fear in the parents. And so naturally, they're going to present in a fairly disturbed way because of what's going on in the family because of the eating disorder. So the idea was, and as I said, this was developed at the Maudsley Hospital in London, and the thought at the time was they would see families come in, and time again, families would bring people in with an eating disorder. They would, at the time, you know, in the mid and even into the late 20th century, they would kind of drop the kid off at the door, and parents would be excluded, and they would receive their treatment, and they would get a little bit better, hopefully somewhat, and even better, significantly improved. But eventually, of course, they would go back home. And when they did, this oftentimes would start a cycle where the kid would experience a lot of trouble, relapse, run into problems at home, be re-hospitalized, and then this cycle would start all over again. And so what the clinicians decided was, well, maybe there's a different way of approaching this, because what we see right now is hospitalization is traumatic for the entire family, and it tends to disempower the parents. The parents don't ever get the feeling that they have the tools that it needs to combat the eating disorder and to help their child out of the eating disorder. And so every time these eating disorder behaviors crop their head up, the only solution at that time was bring them back to the hospital. And that could just start a real vicious cycle. So the thought was, how do we get out of this? How do we help the parents to feel more empowered and maybe replicate at home some of the things that we're doing in the hospital? So some of the underlying assumptions here were that many of the elements of inpatient hospitalization could be replicated somehow at home, and including restoring the patient's weight, and that parents needed to feel that level of empowerment if they were going to help their child and if they were going to resume parental control. Oftentimes what will happen with an eating disorder is that the parents are very effective in dealing with whatever might come up for their child or their adolescent. But for whatever reason, anorexia nervosa in particular sends parents kind of back on their heels and has them questioning their instincts and has them questioning everything that they've been doing for years and years and years with a lot of success. And so they become disempowered and feel like they don't have what it takes to address the issues that are coming up in this particular area. So this was, as I said, a real paradigm shift. And I think more than anything, that paradigm shift was sort of centered around dropping this assumption that the cause of the eating disorder was the parents. And as we'll talk a little bit more about in the Maudsley Approach, or what came to be known as family-based treatment, there's no assumptions that are made regarding the etiology of the disorder. So it has come to be known as family-based treatment. In the academic world, it is most often talked about as FBT, but everyone in the clinical world, I think we all sort of refer to it as the Maudsley Approach. And if I tell a family that we're going to do FBT, they usually look at me a little bit puzzled and say, well, I thought we were going to do Maudsley. So those terms are pretty interchangeable. But basically what you've got is a treatment that says parents are a resource. They are, in fact, the most important resource for helping their child or adolescent get out of the clutches of the anorexia nervosa. Siblings also play a role, but their job in treatment and what we invite them to do in treatment is to play a more supportive role. And really one of the things that we're doing as we're doing this treatment is helping to reestablish and realign the parental subsystem from the child subsystem. And so we want the siblings to be playing a role, but they're to be playing a role within that child subsystem and are assigned a job that is very different from the parents. This treatment is absolutely a team approach, and we'll talk a little bit more about that at the end, but the idea is that there is a primary therapist who is kind of the hub of the wheel, and they're seen as the person who really coordinates all of the other treatment providers who might be involved. So that might be a psychiatrist, it might be a pediatrician. As we'll talk about, it does not often involve or traditionally involve a dietitian, and I'll explain a little bit about why that's the case. So who is it appropriate for? Well, we would say that it's appropriate for kids and adolescents who are above the 75th percentile of what we would expect given their age and height, and are otherwise medically stable. Below that point, we often see medical instability. Excuse me, and I think we would probably want to think first and foremost about an inpatient stay just to restore weight enough to be able to medically not be compromised while they were engaging in outpatient treatment. So below that 75th percent cutoff, we would want to think about a more intensive intervention and 24-hour medical monitoring before they're ready. But it's an outpatient intervention. It is primarily a weight restoration treatment, and I think that's something that can be missed at times and is not highlighted enough. We'll talk about the different phases of treatment, but as you'll see, phase 1 and 2 are really the main body of the treatment, and they really focus on helping to restore the adolescent's weight and get them back on track with normal adolescent development. In terms of who it's not suitable for, if parents have really severe psychopathology, serious discord in relationship between the parents, then it might not be the right treatment for those families. Daniel LaGrange was part of the treatment team at the Maudsley who was working with Yvonne and Chris Dare and Gerald Russell, and when he left there and did a postdoctoral fellowship first at Stanford and then took his faculty position at the University of Chicago, he was the one who brought family-based treatment to the U.S. In general, it's an outpatient treatment as it's been manualized and studied in the literature. It's 20 sessions over 6 to 12 months, and right now the data seem to suggest that the 6-month version and the 12-month version do equally well. Typically, in most of the research trials, the 12-month version has been used, and then the manual was just recently updated, and so the second edition of this treatment manual was just released last year. Okay, so the 3 phases of treatment, as I said, it's a 20-session treatment, roughly broken down like this. Phase 1 is the first 10 sessions, and the parents are charged with really doing the work and making the decisions about what the child will eat, what exercise will or will not be done. The parents are very much put in charge of that role of making all weight and exercise-related decisions, food-related decisions for their child or adolescent. As we move into phase 2 then, hopefully around session 10 or 11, the parents begin transitioning control back to the adolescent as is developmentally appropriate. Obviously, this is going to look real different for an 11 or a 12-year-old patient than it would for a 17-year-old patient because the 10 or 11 or 12-year-old patient might not have that much say in what they're eating for dinner, for example, or portion sizes or things like that. That might be the family has always been involved in that way and been plating up the food and making those decisions, even if in a perfectly healthy 12-year-old. But obviously that would look a little bit different if the patient were 16 or 17 and might be making more of those decisions on their own. So the goal of phase 2, though, is to really help the adolescents start to take control back of those decisions. And then phase 3 is the shortest of the phases, and it's focused on really discussing the adolescent developmental issues. This is particularly important in anorexia because what can happen and what we often see clinically is that the kids are developmentally sort of stunted or will sort of press pause on their developmental trajectory while they're in the throes of the eating disorder. I'll talk about with patients often that the eating disorder, the anorexia, can tend to sort of oversimplify life. If it's all you focus on and your one rule of living is I need to lose weight, I need to eat less, there's a lot you're missing out on. There's a lot of development that isn't taking place while the anorexia is primary. Social development, emotional development, peer development, dating, experimenting with different behaviors, having that first cigarette or drinking, or any of these things that we see as sort of part of that normal kind of developmental adolescence experimentation and learning process, those things typically are not happening at all while the patient has anorexia. And so there's a game of catch-up that they really have to end up doing when they're ready to kind of re-engage, and they have to catch up a little bit with their peers. And so phase 3 is trying to help kind of lay the groundwork for navigating that. Obviously, it's going to unfold over a period of months or maybe even years, but helping the family sort of lay the groundwork for how they will navigate and get the adolescent back on track. We think about session 1 as what's termed the funeral session. And the reason for that is what you're really doing is trying to set up the sort of the frame for the family, that this is a very, very serious disorder, and that if the family isn't able to come together and the parents aren't able to step in and really address things in the way that's necessary, that the patient could die. And we don't want to underestimate this disorder's ability to be fatal. So the goals are to engage the family, to obtain a history of how the anorexia has affected everyone in the family. Sometimes parents will come in and say, well, you know, I've got younger children, but they don't know anything about this. And I always challenge them on that and say, really, I have yet to find a kid over the age of 3 or 4 even who doesn't recognize something has changed about their brother or sister, something has changed about the way that the family is functioning. And so all of the kids tend to recognize that something has shifted and affected things. So it is definitely impacting everyone in the family. So getting a history of that and getting a sense of how everyone's been affected, and assessing family function. What's the authority structure? Who are the conflicts existing between? What are the coalitions that may have formed in and around the eating disorder particularly? And also to externalize the disorder and reduce parental blame. So you're orchestrating this intense scene about how serious this disorder is and how important it is that we act and act quickly, and act decisively as well. And they'll leave the session then being charged with the task of refeeding their child or adolescent. Session 2 then is the family meal, and this has become probably, if people hear about the Maudsley Approach, this is one of the things that stands out. It's very different than most other treatments. I can't think of any other treatment where you bring in a meal to the session. You'll ask the family to bring in a typical lunch or dinner or breakfast, depending on the time of day, and they will eat in front of you. I did one of these last night. I've done many of them over the years, but did one last night and had to acknowledge, as I always do, yes, this is a very weird situation. It is very strange to be sitting in my office around a little table that I've pulled in and having dinner. But what you're doing is you're assessing the family structure and seeing how able the parents seem to be at that time, at the beginning of treatment, to refeed the patient. So I've done family meals where the family brings in a meal of meatloaf and mashed potatoes for everyone in the family, but for the patient with anorexia, they bring in a salad. And gives you a good idea right from the get-go of how much education you're going to need to do, how much you're going to have to work to increase the parents' anxiety about their need to intervene. The ideal situation is they bring in just giant heaping portions of cheesy lasagna or something for everyone, including the patient. It provides then an opportunity for the parents to successfully feed the patient, and what you're doing then is setting up a situation where you're going to ask the patient and ask the parents to help the patient have what we call one more bite. At a certain point in every family meal, the anorexia will step in and say, that's it, I'm not going to allow this patient to have one more bite. I've reached the limit of what is acceptable, and I refuse to go even one bite beyond that. And this is where the parents will lean in, and literally you'll have them sitting next to the patient, and you will coach them through how to firmly but gently prod the patient into having one more bite. So through a non-emotional but consistent message of the importance of having that extra bite, you'll coach the parents into being able to press the anorexia outside of its comfort zone. And the successful family meal is over as soon as the patient is able to have one more bite than what the anorexia was willing to let them have up to that point. The remainder of phase 1 then, sessions 3 through 10 in the manual, can become a little bit repetitive, because what you're really doing is you're weighing the patient at each session, and that's going to really determine the tone for the session, and seeing whether or not you're going to be focusing on what worked or what didn't work, and be very, very concrete and very nuts and bolts about things. So if the patient has gained weight, what did mom and dad do that week that facilitated a weight gain? Were they monitoring every meal? What food decisions did they make? How did they go about making those decisions? And if the patient's weight went down, what did mom and dad do this week that we can tweak and make a new plan for next week and get the trajectory back going in a positive direction? So the focus is really on the weight and on the refeeding. Lots of other things will come in. Obviously, there's lots of things going on at home. Families will oftentimes want to talk about other things, and the therapist's job is really to keep them kind of laser focused on the refeeding process and laser focused on this needs to be our primary issue. Yes, other things will come up, but we would argue that outside of, say, suicidal behavior or self-injury, nothing trumps this level of starvation, and it has to be our main focus, at least during this time of treatment. Phase 2 then moves, as I said, into helping the adolescent to learn how to eat independently, or as independently as we would expect given where they are age-wise. This happens at about 87% of where we would want them to be in terms of their expected body weight, and when the patient is able to eat without a lot of struggle. So they still might be having a little bit of difficulty managing to eat all that the parent puts in front of them, but you're not seeing really big behavioral outbursts and really big temper tantrums. They're able to participate with some degree of compliance, and that the parents are starting to demonstrate that they really feel empowered to manage it. And that last point is critically important, because if the transition to phase 2 begins and we find that we've started it a little bit too early, then we want to fall back into phase 1, and you want to make sure that the parents know exactly what they need to click into and what the behaviors are that they need to be doing to get things back on track if it falters a little bit. I always tell people when I'm training them that these transitions from phase 1 to phase 2 that is probably the most difficult part of treatment. It is more of an art than a science, I think, of knowing when you make that phase transition. And sometimes it goes really well, and sometimes it doesn't, and you have to fall back into phase 1, do a little more work, and then try it again. The goals then obviously are to transfer back the power and the responsibility back to the adolescent, and to maybe start exploring some of the developmental issues related to the anorexia, which you may or may not get to until phase 3. And then the interventions obviously are listed there, assisting the parents in navigating this return of control, this phase transition, continuing to highlight the differences between the adolescent's own needs and those of the anorexia. And again, this externalization of the disorder is really critical throughout. We want the parents and the adolescent all on the same page that the problem here is not the adolescent or the parents, but the Phase 3 then gets to trying to address and again just sort of setting the groundwork for how to address these adolescent issues. By this point, we would want their weight to be about 90% of what we would expect, and that there might still be, though, some shape and weight or food-related concerns, but that their weight is in a much better place, and that the adolescent also feels fairly competent and confident in their ability to be eating what the parents would like them to be eating and what's necessary to maintain this level of weight and continue to gain back up to 100% of where we would like them to be for that goal weight or goal weight range. The goal then, shifting the parent-child relationship with the remission of anorexia. Obviously, this is a very strange situation for even a young adolescent to have their parents this involved in their eating and making this many decisions. It probably hasn't happened since they were a very young child. And we want to start to shift back to a more normal relationship in terms of the adolescent having independence. But also reviewing and problem-solving adolescent development and thinking about where are the places that the adolescent may have been held back in terms of their developmental trajectory, and where can they start to move forward again, and how they start to do that. As I said, this isn't a situation where you'll necessarily get there with them, but really trying to just think through and problem solve with them ahead of time and lay the groundwork for how they'll go about doing that. And then lastly, at the end of phase 3, just having a nice termination of treatment. Interventions, then, I think, as I've mentioned, modeling the problem-solving behavior, reviewing what is normal adolescent development. Some parents, especially if this is their first child, might not have a good sense of what that's supposed to look like, and so providing a little bit of psychoeducation around that. Checking again with the parents about their relationship as a couple. Oftentimes parents will report that because of this laser focus on the anorexia, they haven't been able to focus too much on other things, including their own relationship. And it can really challenge the fabric of their relationship. So making sure that the parents are checking in with each other again, that they can get on the same page and work on their own relationship again. And to a certain extent, keeping a level of anxiety, an appropriate level of anxiety there, that you want them to be a little bit worried about relapse and having a plan in place. What's nice is by this point in treatment, if things have gone well and they've progressed to this point, the plan often focuses on just falling back on the behaviors that they've already learned. As I always say to parents, by this point in treatment, you can't unlearn what you've learned. You are the one who figured out how to help your child out of the anorexia. And so if it starts to crop up again, if you see the first signs of relapse, and we want to think through with them, what are they looking for? What are they going to be keeping an eye out for? But if they were to see those things, they know what to do. And I really try and make sure that they leave with that feeling of, we've got the power to stop this disorder. We did it once, and we could do it again if necessary. But encouraging them to stay somewhat vigilant for that, at least immediately following treatment. Okay, so I wanted to talk a little bit also about the research support for family-based treatment. Right now, as it exists as of the end of last year, this is the entirety of treatment studies in adolescents with anorexia nervosa, despite the fact that the disorder most often occurs in adolescents. This is it, and you'll see that the first uncontrolled studies weren't started until the late 70s. So this isn't unlike my colleagues in depression or schizophrenia, who have decades and decades and decades of research that they can take a look at, and treatment development. We're still fairly new in trying to figure out how to help people with these particular disorders. And the randomized control trials are even fewer. And I would highlight the Locke and colleagues 2010 study as being really the best study that we have, and I'll talk a little bit about that in a moment. Right now we only have 3 treatments with any kind of empirical support. So a family-based treatment, there's an individual treatment called adolescent-focused psychotherapy, and I'll talk about that in a moment, and behavioral family systems therapy, which is in some ways very similar to FBT, and FBT has tried to tweak and develop that more to be more effective. But there's really been a focus on family-based treatment because it's shown the best results in these treatment trials. Right now we know that it has more rapid recovery as compared to the individual treatment, both at post-treatment and at 5-year follow-up. And those were studies originally done at the Maudsley Hospital and then extended out from there. That the response rates are looking like as high as 80, maybe even in the 90s in terms of adolescents who no longer meet criteria by the end of treatment, and has a potential to reduce hospitalization costs by up to 70%. Okay, so I wanted to talk a little bit about that Locke and Lagrange trial that they did in 2010, and that's because this is the what I think of as the best powered and best designed study that we have so far, comparing 2 active treatments, so adolescent-focused, the individual therapy, and family-based treatment. And this was done at Stanford and at the University of Chicago. The primary outcome was full remission, that is 95%, and that's a higher bar than we've seen in a lot of the previous studies. So they wanted to set the bar high and say, if we're going to say that this treatment really works, let's make sure that they're really achieving a significant weight gain. And then also looking at their eating disorder examination, the gold standard measure of eating disorder psychopathology, is it within 1 standard deviation of community norms. The secondary outcome then was partial remission, that is weight gain greater than 85% using the CDC norms. And this was thought of as kind of approximating the old sort of standard, which was the Morgan-Russell outcome criteria, but a less strict criteria to measure. So the participants in this study were 121 kids aged 12 through 18 who met DSM diagnostic criteria for anorexia. As I mentioned, the main outcome measures were full remission from anorexia, that is above the 95th percentile. There were no significant differences in full remission between AFT on the left side and FBT on the right side at the end of treatment. However, at both the 6-month follow-up and 12-month follow-up, family-based treatment was superior both for full remission and partial remission. This is a graph just showing remitted patients at the end of 3 months and significantly higher in family-based treatment than the individual adolescent-focused treatment. And this was relapse rates at the 12-month follow-up, and as you can see, at significantly lower rates of relapse for FBT as opposed to AFT. So FBT was superior to AFT in promoting full remission at follow-up, superior to AFT in promoting partial remission at end of treatment. More participants treated with FBT reached weight restoration by the 3-month window, and then the maintenance of remission in FBT was superior to AFT. Some variations have been done, and I mentioned there was a 6 versus 12 month. Both seem to be effective. The other variation that's been studied was separate versus conjoint, that is all family seen together, which is sort of the traditional version and the manualized version, versus seeing the parents separate from the patient. And we do this in clinical practice most often when we have very highly critical patients, highly critical parents. So we know that FBT is effective for children and adolescents with anorexia nervosa with a short duration of illness, effective as a brief form as in the longer form, conjoint or separated, that the effects and the benefits that we see are sustained now in research studies at 4- and 5-year follow-up, and that for adolescents with BN, there's also a manual for that using FBT, which I didn't talk about today, but I can talk more about if people are interested. and this seems to be promising. There's a trial right now underway at Stanford and the University of Chicago looking at FBT for BN versus the gold standard treatment in adult CBT for BN, and those results. I think that study is wrapping up in the next few months, so hopefully those results will be out by the end of this year. Okay, so just thinking about how to talk to potential families who initially are coming in and usually are a little bit scared of confronting the anorexia. As I said, it has a way of kind of sending people back on their heels. I like to talk to families about the fact that FBT has the highest remission rates, that it's a treatment that we can say with some confidence will work for many patients. Try and reassure parents that they have what it takes. They didn't suddenly lose their intuition on how to parent their child, that it's really the anorexia that sent them back on their heels, not some sudden loss of knowledge. But preparing them also for the fact that this will be a big commitment. They're going to be asked to take a very active role and spend a lot of time addressing the disorder, but that this was something that is probably very important to them because their child's life is absolutely at stake here. Some research has been done looking at particular family dynamics. Divorced and single-parent families do just as well with FBT. In terms of comorbidity, we typically will say only suicide or self-injury trumps the starvation, and that the comorbid disorder might be treated psychopharmaceutically, but maybe not with psychotherapy until the end of the 20-week trial. Contraindications, as I mentioned before, parents with a severe psychiatric or medical diagnosis, an abusive parent. There's still some question and some research being done looking at parents with an eating disorder and whether or not that is really something that contraindicates treatment. In terms of dissemination and training then, the clinical manual, as I mentioned, is in its 2nd edition, was published last year. There's also a parent handbook that's available. And then for people who are interested in becoming certified in family-based treatment, they can look at the Train to Treat for ED website and go to the Training Institute for Child and Adolescent Eating Disorders, which runs 2-day workshops, usually 2 or 3 times a year, and then offers supervision in this treatment as well. This is just a screenshot of their website, and then the different centers around the country right now that offer training for family-based treatment, and these are the certified providers, with the yellow stars being at Stanford and the University of Chicago.
Thank you, Dr. Doyle. That was great. So before we move into the question and answer period, I just wanted to step in and give you guys a brief word about Valent, who brought us this lovely content today. Valent is an electronic medical record and practice management software company specifically for behavioral healthcare practitioners. I'm going to put up a quick poll. So if you are interested in learning more about Valent, feel free to, on your screen, go ahead, select yes or no, just so that we know who to reach out to in those interested parties. We offer, like I said, everything from electronic medical records, note writing, and billing. I'm going to leave this up for just a few more seconds, and then we're going to get directly into the question and answer period with Dr. Doyle. Additionally, if anyone is interested in consultation, I'm going to put up a phone number at the end of the slide deck today, and you can go ahead and call Dr. Doyle's office and set up a time to speak with him directly if you have any patient consultation needs. Leave the poll up for just one more second, so get those answers in. Thank you all for your participation in that. And let's move directly into the questions that we have up currently. So feel free to go ahead and use the question box to go ahead and type in any questions that you may have. And now we have a question here from Mary to start out. A question about what do you tell the families about what's going to be happening in each stage? How do you position that to them?
That's a really good question. What I typically do with the families is talk to them about all 3 phases at the beginning of treatment and outline, excuse me, outline that they will be in charge in the beginning, and I'm really clear with them about the fact that what decisions I'll be asking them to make. So that prepare them for the fact that I will want them to be monitoring all the meals, or have some other member of the family, some other adult who's monitoring all the meals, and that they will be making the food choices in terms of the content of the meals, the size of portions, and staying with their adolescent during the meal and after the meal, especially important if part of the clinical presentation is that there's purging going on afterwards. We'll want monitoring to take place, and that will be the primary mode of the therapy, that they will be really, really involved, and that they will be doing quite a bit of legwork in terms of what's going on at home, and then preparing them for the fact that usually families are a little bit intimidated by that, and saying, I know you have what it takes. You've fed your child or adolescent up to this point, and have always been successful about that. You know what to do. In some sense, what you're really just trying to do is empower them and help them to remember they have what it takes. They have the skills that are necessary. They just need to almost have kind of permission to parent around this issue again. And then, like I said, preparing them for the fact that at a certain point we'll start to transition back into having your son or daughter take a more active role in making those decisions for themselves again, and then we'll talk a little bit about developmental issues.
And it looks like we have another question here. It's about treatment for a 20-year-old whose weight might not be in the anorexic stage, but their behavior is. Do you feel that FBT would be applicable in this scenario to get the parents involved?
I do. Right now, there's a research underway being led by Eunice Chen out at Temple, who's looking at, I was involved in developing the manual for what's being called right now FBTY, or FBT for young adults, where we apply the same principles and use the same approach with young adults between the ages of 18 and 25. I would say that the biggest differences here are that obviously the patient has to have a little more buy-in than we would expect from a younger adolescent patient, where the parents have a lot more leverage. As they grow older, they're going to have less leverage and will have to be a more active participant in letting their parents make those decisions. So that takes some time to set up. But in terms of your question about not meeting the weight criteria for anorexia, I see oftentimes kids and young adults who are not at that, what the DSM says, 85th percentile or below. FBT works just as well, and I've had just as much success with it, using it with kids who are at 86 or 87 or 88. At the end of the day, 85th percentile is a somewhat arbitrary cutoff to have, as it were. So it does seem to be just as successful as in families and patients who are a little bit higher weight but are exhibiting all the same behavioral characteristics that we would think of with anorexia.
Perfect. We have another question about how often you interface with other providers, whether that be nutritionists or primary care physician, and do you ask that you only tell the family about weight gain and weight loss in those cases when you're speaking with the nutritionist?
Yeah, as I said before, the idea is that the primary therapist, is really the hub of the wheel and will have quite a bit of contact with the rest of the treatment team. And the communication needs to be very transparent. The more that the family and the adolescent are getting the same message and consistent messages from all members of the treatment team, the better that is. We always, I tend to share the weight with the patient. I want them to know what their weight is. If we're going to use that as our primary outcome measure, I want them to know how they're doing. And so I would want all members of the treatment team to be involved in sharing weights, talking about meals, talking about food, being really open with the family and the patient with all those different aspects of how things are going.
Perfect. It looks like we have some other questions just about your thoughts about the introduction and use of medication by another provider treatment.
Yeah, that's a really good question, and one that comes up fairly frequently in this treatment. Right now, there are not a lot of data to say one way or another. The trials, there are no RCTs that I know of that have looked at the use of medication for anorexia. I know Tim Walsh did one a number of years ago looking at SSRIs and found that there was no significant effect. I'll say that clinically, most often what psychiatrists are prescribing is some of the atypical antipsychotics, and have found that, again, anecdotally speaking, they've found that there's some success in using those medications to reduce the agitation and some of the anxiety that comes up around mealtime. And so I'd say those are the ones that are most commonly used. And I typically will recommend a referral and start to go down that route if the parents are facing a lot of resistance, or if the child or adolescent seems to be really struggling a lot more with being able to comply with what their parents are asking them.
And then just before we move on to the last few questions, I want to let you know, if you do type in a question and we don't get to it today, we will be following up with all of those via email directly. Additionally, I have put up the number and contact information if you are interested in consultation with Dr. Doyle on the screen currently. I'm going to resume. Hopefully we can get through a few more of them, but I do want to be respectful of your time during this workday. So we'll run through a few more, and we'll probably stay on the line for another 5 to 10 minutes. So we have a question here actually about the family meal and if that's ever delayed in the treatment, if it's done a little later.
Yeah, the family meal in the manual is done in session 2. I think it can be problematic to do the family meal later. Typically, I don't wait. And the reason is that the family meal gives the therapist, as well as giving the family good information about what to do and how to address the resistance that they're likely to see, because they're getting that sort of in vivo coaching with the food there. It also gives the therapist a good sense of where is the family and how much do you need to push. As I said, some families will come in with a fairly Spartan family meal, and you know that you've got to provide a lot more education about what they need to do and try and raise their level of anxiety. But again, you're also asking them to do something that up to this point is pretty difficult, and something that they probably have not wanted to do, which is to take a really active role in confronting the anorexia and saying to their son or daughter, you need to eat this plate of food that I put together for you. They're gonna struggle with that. Every family struggles with that a little bit, and so I want them to have the coaching as soon as possible in that, and so I wouldn't want to delay the family meal for that reason, because they really need the skills to be able to be effective.
And then we have another question just piggybacking on the family meal, and about what if the parents can't convince them to take that one more bite? How long should you/they insist on the patient taking that?
Yeah, it's a really good question. I typically schedule, well, I'll start by saying that Daniel LaGrange, who I worked with for many years and is still a good friend, likes to sit there and gloat that he has never had a patient who didn't take one more bite in the family meal. I wish that I had that kind of stellar record. I do not. I've certainly had patients who are ready to wait me out. I typically schedule it as a 90-minute session just for that reason, so that I've got a little time built into the schedule for when the patient says, there's no way I'm eating that next bite, and I can step in and say, well, we'll wait you out, and I can really mean it. What I try and do in those situations is help the parents see that this is what we're up against, that we've been just asking for one more bite, and that, your son or daughter has been so resistant for 20 or 30 or 40 or 50 or 70 minutes now. It's that critical that we step in because they're really, the anorexia is so strong. But try and help them leave with the feeling that if we waited it out, they would do it. And coach the parents that in the beginning, sometimes dinners can last 2 and 3 hours. And again, this is the kind of commitment that I think you want to prepare them for, that it can be a really big time commitment. And sometimes I'll ask parents, are you able to take off work for a week or two? Are you able to keep your kid home from school for a week or two? Again, they would be getting this kind of treatment in an inpatient facility, but we want to be able to try and replicate that at home if we can, because it's a much better environment for them. So it can take a while, and you want to prepare parents for that.
Okay, and this is going to be the last question we get to just in the interest of time, but there was a question about, do you introduce any relaxation techniques to help the patient manage the anxiety that can come about?
That's a great question, and it is not addressed in the manual, but in clinical practice, I can't think of a single provider I know who doesn't do that at some point or another. And you don't want to deviate too much from the focus and get too involved in that, but yes, absolutely, I'll give them progressive muscle relaxation or some cognitive techniques. Utilize any relaxation techniques that you as the therapist know to help try and reduce that anxiety, because certainly it comes up and you want to be supportive of the fact that this is very, very difficult for the adolescent to be confronting the anorexia in this way. So great question.
And again, I know that there were some questions that we did not get to today, so we will be following up with each of you individually about those items. We will also be posting a recording of today's webinar, not only on the Valent site, but we'll also be emailing it to all registered attendees of today's talk. If you have any questions about that, my contact information is on that first slide, and you can go ahead and just give us a call here at Valent, and I can direct you to the appropriate resource. But thank you again for your time today. Thank you, Dr. Doyle. I think everyone, if we could hear applause, we would at this point. So thank you all again, and have a great rest of your week and evening.
Thanks, everyone.